Hello, I'm Laura Johnson. I am a QL1 community pharmacy resident at the school pharmacy. And today I'm going to talk to you about the recent communication the FDA sent out on DPP-4 inhibitors associated with severe joint pain. So a little bit about DPP-4 inhibitors. They're for the management of type 2 diabetes as in conjunction with diet and exercise to improve glycemic control. They recommend starting therapy after metformin monotherapy has not met your patient's target A1C. Medications in this class include sitagliptin, saxagliptin, linagliptin, and alogliptin. And the way that they work, they inhibit the DPP-4 that cleaves GLP-1 that is released when you eat a meal, and so it lowers the blood glucose by inhibiting glucagon release and also stimulates insulin release. But DPP-4 also has numerous other functions in the body, and it's on several different cells as markers, and in particular lymphocytes and fibroblasts for this communication from the FDA. It's also known as CD26, and that is a T-cell activating antigen expressed on many cells. So whenever DPP-4 inhibitors are given, this can lead to T-cell activation, which leads to increased release of inflammatory mediators, which could possibly cause the joint pain associated with these agents. So the FDA had identified 33 cases of severe joint pain in patients from 2006. They used the FDA adverse event reporting system to identify these cases. They found that 10 out of the 33 cases they identified may have been caused by an autoimmune event. So these patients may not have presented until later on without the help of the DPP-4 inhibitors. So the most to least reported medications, sitagliptin had 20 cases, saxagliptin had 5, linagliptin 2, and alogliptin had 1. So individual case reports include a 45-year-old female. She had type 2 diabetes. We started on vitagliptin, which is not FDA approved, but it's used in Europe. She was started on it in October of 2010. She started experiencing arthralgia in her knees and her ankles, and synovitis and belt wrists. They performed immunologic tests and radiographies of the joints, and all of those came back normal. But they did find a chronic hepatitis B infection with a low viral load of 30 copies per mil. So they did a liver workup. They checked her liver enzymes, proton enzymes, and did a liver ultrasound, and all of that came back normal. So her PCP discontinued the vitagliptin in April of 2011, and her arthralgia and synovitis resolved within 1 month. Excuse me, sorry. Okay. So the second case report that is interesting is a 48-year-old male who had type 2 diabetes, started on sitagliptin. He developed morning stiffness and progressive worsening of pain and erythema in his metacarpal joints. So they did a rheumatological workup, and it was negative for connective tissue disease. He developed a rash 6 weeks after starting the sitagliptin, so they discontinued the medication. The rash and the arthralgia resolved, and they switched him to saxagliptin, and the arthralgia returned within weeks of initiation. So this guy was re-challenged with a different DPP-4, and they had the same result. So this case shows that it's possible that even though a patient has the arthralgia on one, they could possibly have it on the other as well. But they discontinued his saxagliptin, and his symptoms resolved again. Lastly, we had a 56-year-old female with type 2 diabetes that started sitagliptin in 2010, June of 2010. She presented to her PCP with in July 2010 with bilateral symmetrical polyarthritis in her wrists, ankle, and her fingers. And nuclear antibody tests were positive. They found that she had Sjogren's syndrome, and that was diagnosed based on her arthralgias, dry mouth, dry eyes, and dry skin. So they started her on methotrexate, hydroxychloroquine, and prednisone, but this therapy failed. They discontinued her sitagliptin in August 2011, and her polyarthritis resolved within 1 month. So in conclusion, patients that come in with complaints of joint pain, their med list should be reviewed for DPP-4 inhibitors to possibly save from expensive and extensive tests or evaluations that can be run. Most patient symptoms did resolve when DPP-4 inhibitors were discontinued, and you should advise your patients to continue therapy until they talk with their primary care provider for what other possible symptoms. Any questions? Yes? Okay.
So the three test reports that you focused on, were those three or were these three people that you considered?
These are 3 people, it was 3 people in literature. Sorry, most of the case reports, maybe all the 33 cases that the FDA found were not written in the literature. All these case reports came from overseas.
Do you know any of these test reports, or any of these people on the current therapy?
They did not mention that in the case.
Well, because it seems like the hypersensitivity reaction, most of those occur in current ACE therapy because before it's so ubiquitous. And of course, for ACE inhibition, inhibit ACE, the primary secondary metabolism is DPP-4.
Yeah, and DPP-4 also affects substance P as well.
Right. So most people show up DPP-4 also.
I did not see that in the case reports. Yes.
Do you know off the top of your head, were any of these patients re-challenged with this? Like, is this something if they were to take it again, or is this a permanent discontinuation of the drug if the patient experiences this?
In the first case and the third case I presented, it was permanent discontinuation, but the second case, he was re-challenged. Interestingly, he was an Indian physician that re-challenged himself. And it ended up with the same symptoms. But that was the only case that I found that a patient was re-challenged.